So, hi everyone, welcome to today's office hours. Today we have a case being presented by Dr. Sean DeLacy at Lurie's, as well as a case from our registry. We'll have Doctors Phillipson, Dr. Greeley, and Dr. Naylor on today's panel. And reminder, no PHI may be discussed since we record and post these sessions.
All right. Do you want me to share my slides, Ava, or did you have, I think you have them, or no?
Yes, I have them, so I'll go to your case. Can you guys see my screen?
I can.
Yes.
Okay,
Yeah.
go ahead whenever you're ready.
Okay, I'm thinking this will probably be relatively straightforward for you guys. I just haven't had a case like this yet, but this is an 8-year-old that I just got in my clinic who doesn't have diabetes and but was noted to have an elevated A1C on screening from genetics of 6%. Has a non-obese BMI, no DKA, a C-peptide of 1.36, although I don't think was fasting. And they hadn't collected diabetes antibodies. He is on losartan, mycophenolate, and tacro. I think his other past medical history is on like the next screen, which will show why he is on those agents. And when I saw him, his BMI was still normal, and his A1C was 5.9 after the family like eliminating some like sugar containing fluids at home. Go to the next screen. Okay, so the reason he was on the tacro and the mycophenolate is because he had end-stage renal disease, actually from posterior urethral valves, and so had a renal transplant in 2019. He did have prematurity as well, has developmental delay and pretty significant autism. Has a G-tube, had G-tube dependence for more so uh, since he was premature, but had been weaned off of that. Also has some heart issues, the dilated ascending aorta and the LVH. So when I got him, I like kind of looked through what his blood sugar history had been. It looked like he was on high dose steroids right before the transplant. Um, and so when I looked through, there had been a fair amount of blood sugars that had been taken before. The only one I could find above 200 was right before the transplant. And then intermittently, it had kind of random blood draws that were fasting and non-fasting that were ranged from 107 to 133. It looks like renal had intermittently been checking his A1Cs, and the first time it was like above 5.6 was in 2021. It was 5.7. And then no family history of autoimmune disease or diabetes of any kind, or renal disease for that matter. He had eventually been evaluated by genetics, who did a Fragile X screening and then also did a microarray, and they found this 17q12 deletion that included the HNF1 B gene, which is why they suggested the A1C screening because of its relation to diabetes. And then got the A1C of 6 and sent him to me. And family on their own without kind of like dietary guidance had been trying to limit kind of like juice and things like that. Go to the next screen. So I mostly just kind of like started looking through literature about like what to do. So I really randomly, I don't know why, but I have um 3 other kids which with an HNF1 B mutation, including 2 other ones with a 17q12 deletion. But I've received them at other stages of their diagnosis and not at this stage, 2 of which were like 100% insulin dependent by the time I saw them. The other one had like severe hypomagnesemia and also had obesity. And so I treated her with an SGLT2, which is like controlling her blood sugars for now and presented with like relatively low, like in the sixes. This kid, I just was struggling with, when I looked at kind of like long-term stuff, it says most of them like end up insulin dependent, but I I wanted to make sure that there was like nothing else that I could offer, anything else that would like delay the course, kind of like what you would recommend in terms of like monitoring at this stage as I'm like kind of waiting for him to become insulin dependent, I guess.
I think one place to start is just to really clarify that it is not clear if individuals with HNF1 beta Modi truly become insulin dependent or if that's simply what people put them on. So I think that's one
Okay.
thing to just keep in mind that you should um, in the other patients that you follow and in this child, depending on their course, like consider other things because
Yeah.
it's not necessarily that they're insulin dependent. It is just that they definitively don't respond to sulfonylureas and with the hypersensitivity that HNF1 alpha and HNF4 alpha do. And then I think it's sort of like what has historically happened. And there are little, here and there reports of, just like in your patient using SGLT2 inhibitors or trying GLP-1 receptor agonists, there's some like, kind of theoretical mechanisms of action in those medications and things with HNF1 beta, where it certainly makes trying either of the two seem reasonable.
Mhm.
But I think that that's just one thing to like clarify that really we probably a good portion, certainly I'm sure some are like that's the medication that they would need to control. But I think that the fact that most individuals with HNF1 beta Modi have been treated with insulin is more reflecting what was available, sort of what was the next rational step. So
Mhm.
that's sort of like the jury's still out.
Mhm.
Um, I have had a couple of children who are sort of presenting in this you know, no clear pathway. There is no obviously, standard of care to follow or some,
Mhm.
clear clinical guidelines. And so I, at this point, have generally just been monitoring A1C and sort of following them
Mhm.
up, not quite as frequently as I would someone with clear diabetes, but still continuing to see them in my clinic because of the risk.
Mhm.
I haven't yet tried, I haven't tried sort of preemptively to start
Mhm.
anybody on anything. I haven't had a either by age or by body weight, not felt like I had a lot of room for maybe an early course of GLP-1 or anything like that. So like I actually have been more in the waiting area when I am the actual clinician.
Mhm.
So that's sort of my initial 2 cents, and I'll let others add some of theirs before we keep discussing.
Yeah, and A1C is kind of what you're monitoring in them.
Yeah, that has been what I've been monitoring. I have done, the screenings for the other organs that can be involved,
Yeah. Mhm.
sort of in my initial first pass, but
Okay.
otherwise, yeah, been monitoring A1C.
Okay.
So maybe what I'd like to do is take a step back and understand like the whole diagnostic view here. So
Mhm.
this child has a 17q deletion, and that's probably accounting for the mental status situation.
Yeah.
So,
Yeah.
so we don't usually call that autism. So it's
Right.
interesting that that's in there. So that's one thing I don't completely understand. And maybe the people who are seeing the child don't understand what the 17, I mean, is understand this is a
I think,
17q
yeah,
syndrome?
and I think that's probably like my failure of updating it is that the diagnosis of autism came first and the 17q12 deletion came after. And so it's probably just I think he had neuropsych testing that said autism and then had genetic testing thereafter.
Because it is interesting. So, because
Mhm.
Ro, because we talked about the group, especially in was it in Finland, Timo's group that has the 17, so many 17q
Mhm.
HNF1 beta folks. I
Mhm.
mean, is there diagnostic overlap, would you say, between autism and 17q?
Either, yeah, no, the autism being a feature of the 17q12 or 1,2 deletions syndrome is known. So I think it's just more that true and, not
Overlap.
multiple things happening for him. That,
Yeah.
it's, explaining both. But yeah, that is there.
Yeah,
Um, yeah.
And then it's incredibly bad luck that the
I
bio
know.
the right the urological problems resulted in kidney failure.
Right.
Was there any hypomagnesemia before the
I
you know
don't think so. I mean, it was pretty early, like the transplant was when he was like 2, I think. Or
because
one.
usually we don't see the hypomagnesemia until they're like teenagers, I think. Is that right, Ro? You have this more in your head than I do.
So I think that, this is another one of the um things that are underreported because not
Yeah.
everybody is looking for it. Um, but so far, and actually I have some labs that I need to look at. But so far, I in my pediatric patients haven't had this be an issue, but I've been screening for it. I do recall one of our colleagues here who had, a individual with significant hypomagnesemia and the magnesium wasting. I believe they were either late adolescence or very early adulthood.
Yeah.
I just wanted to be sure that because
Yeah.
they would have looked at heart and magnesium before the transplant, and in some ways it's interesting. Kidney failure should actually cure hypomagnesemia because it's a leak, I think, and so we have thought about that. I mean, you don't want to remove somebody's kidneys just because they have hypomag, but we had that one case in a teenager or a 20 something, not a few, maybe a year or two ago,
Mhm.
who had such profound hypomagnesemia that she couldn't be corrected. She was either having diarrhea from the magnesium, or symptoms of hypomag. And what do you do? I mean, she needed IV magnesium all the time. And but again, that was an older child. So I think here, because the kidneys have failed, that's not going to happen. So
Yeah.
that's interesting sort of.
My 3 other patients are all teenagers, and 2 of them have hypomagnesemia, and the third one has had a transplant already and does not have
Yeah,
hypomagnesemia.
so I think that, that's the point, is it has to be a kidney defect.
Yeah.
What's also, I think, interesting here is the tacro.
Right.
So, in adults, we wouldn't even think about something else. We just say tacro causes diabetes, and that's the end of it. So here
Right.
you have like now a double whammy. So you have 17q and the HNF1 beta affecting beta cell development, and you have tacro interfering with probably mTOR and beta cell function. So that creates an additional wrinkle. A
Yeah.
lot of those folks go on insulin early on
Right.
because there's basically a insulin secretion defect. Now you have two, right? So now you have two things,
Right.
and it's probable that that's going to need insulin at some point, unless I mean, there are, I don't know, the trial would qualify. There are studies on tacrosparing immunosuppression in kidney transplant, but I don't know what age. I probably 18 and above.
Yeah.
The other point I think is interesting. Well, I mean, so that's a lot. So that totally changes how you might treat HNF1 beta related diabetes. And as Rose said, maybe in some kids, maybe you don't need insulin, but that's been the go-to. It seems like the insulin deficiency can be reasonably profound,
Mhm.
and we do end up seeing people on insulin. But the studies on, for example, GLP-1s, I think we're trying those in a lot of different situations, and those are encouraging. But I don't think there's no series here that we could really help out with.
Right. Okay. That's what I kind of figured. I mean, his BMI is normal, luckily. He's not like he doesn't have a low BMI, which is good, I guess, if I end up considering one of those. But I guess there's nothing besides like an SGLT2 or an GLP-1 if he starts rising. You wouldn't treat him until he's in the diabetes range, I would assume, in terms of A1C. Like in your guys' mind, there's no reason to like treat us earlier than that. I'm just waiting for
Well,
it
you
to
could make
develop.
something up. I mean,
Yeah.
you could make a story that
Okay.
giving GLP-1 ahead of time to make more sort of a robust insulin secreting cell, but
There's
there's
no
no,
real. Okay.
no, that's just, again, you're making stuff up and probably you
Making.
want to do it on protocol.
Okay. Okay. That's kind of what I thought, but I was like, I guess I'll just wait. I mean, he's pre-pubertal, obviously, so I'm just kind of anticipating as he gets closer to puberty, it's gonna be puberty that's gonna kind of tip him over. Um, but
Now there is more stuff to consider. I mean, again, Roe is our HNF1B expert. So, but in terms of or out extra pancreatic effects
mhm,
and extra kidney effects, there are other things to consider.
mhm,
Yeah, I mean, what I was going to add, just in terms of thinking through, the question of, specifically focused on right now the risk for diabetes. Like already discussed, there is this medication that you're as long as he's on it, you're never really going to be able to sort between the two. We also know that, of course, while the risk of diabetes is there, both genetically and from the medication, it's not a foregone conclusion, which is part of why
mhm,
um, I, up to this point, have waited until there is like a clear
okay,
diagnosis.
mhm,
Um, it is, of course, as Lou said, I think it is very truly reasonable to have a relatively low threshold for saying maybe trying to do something protective, right? What is the cost of, you know, pre-diabetes, not the way that we think about it and as a precursor to type 2, but obviously we try to treat. That's really more about hoping that we'll reverse the progression to type 2 diabetes. I don't, what's not known is if you say added something, would that change the trajectory or not? And so I think it's a hard um that I think that's shared decision making. Like whenever, it's sort of the way that I will start metformin in children who have obesity and are at risk for type 2 diabetes with prediabetes, even though the data is not really there. I kind of show my hand to the family and kind of then say like, what do you think? Particularly with options where we feel like there's either a low risk of harm or, just reasonable justification. But um, that one's, I think either course is reasonable with shared decision making with the family, really. I, as Lou said, of course, there are the other things to screen for. Some increased risk, obviously, of wow, my brain just tried to think of four different things and is now thinking of none. So I'll start with the hyperparathyroidism, which is not the most common one. So I don't usually start there, but there is an increase of their risk there. There's increased risk of some biliary conditions. There's the LFTs, which we think are just you check them to say, yes, they're elevated, maybe watch for stability before saying this is just HNF1 beta, and more to make sure people don't um, over,
mhm,
try to evaluate. We know it's a feature and kind of leave it there. And then the fecal elastase, we know that that there can be malabsorption. That's not a one and done. That definitely develops over time. So that's not, normal today and then, forget about it. It's like repeat screening, and there's not, to my knowledge, anything to say like how often you would do that screening. So that's a little bit of things that are being worked out.
mhm,
I know that there was actually just recently an HNF1 beta publication that came out of maybe India, I want to say, that I have it got my open, or was it what is it called? Not open evidence, undermine. My undermine gave me my like notification that hey, a paper of
mhm,
interest is waiting for you. But that was over the weekend, so I haven't
mhm,
had an opportunity to see if there's maybe any new insights to glean from there
mhm,
in terms of trying to help with these decisions where lots of options would be reasonable. But I do think, certainly doing that screening and reminding the family that there's all of these other things to be sensitive to. I do think in this case with the tacrolimus also
mhm.
being there, it's definitely really, really reasonable to consider trying to do something early. It's just the question of then what would it
Yeah.
be?
Is there any reason pathophysiologically that, like, I'm just thinking about having that conversation with the parents in like 6 months. Is there like a reason GLP-1 versus like metformin versus like, I don't know that I would have to have a conversation with kidney honestly about any of these.
Yeah.
Anytime there's a renal transplant, honestly, I talk to them about all of them. Um, but is
I'm
there,
a metformin hater, so
you would say no metformin?
well, absolutely not. And I'll tell you why, as my mother-in-law used to say. But I think that what we have here is insulin deficiency problem, two
Right,
different ways. And metformin is an insulin resistance drug for
right.
the most part.
Mhm.
And if the kid was morbidly obese and was on high doses of insulin, maybe
Right.
so, but I don't see any role here for metformin, just to
Okay.
take a hard line. And
Yeah.
maybe my colleagues will disagree with me, but
But-
I wouldn't do that. And then
Mhm.
I think the other thing that if Ro was feeling better, she would mention the urogenital stuff. So I don't know whether this is a boy or a girl.
It's a boy.
So, absence of VAS, then probably there's nothing, I mean, nothing to do about that, but there's multiple issues that could happen. So that's one of them. Um, in a girl, there's all sorts of uterine abnormalities and other sorts of things, duplications and bicornate and things. But here, absence of VAS has been reported. Uh, as I say, I don't. One might imagine you could say that's a good thing, but um, it is something to note, and there may be other subtle abnormalities as well that may cause some consternation in the future.
Yeah. Yeah. Our genetic department's really great. So I know that they like end up following a lot of these things, although it often slips. There's things that slip through. I actually couldn't find anything about this in the literature, but another one of my patients has primary ovarian insufficiency, like looks like a totally normal uterus and ovaries on her ultrasound, but did not go through puberty. I'm inducing it. No.
Well, it's not like there's 10,000 people with,
Right.
HNF1 beta that have been reported, and which is one of the reasons why we're trying to capture all these folks in the registry.
Mhm.
And to be able to do that, I can tell you, well, Ava can tell us how many, or maybe Ro, how many people with HNF1 beta we have, some of whom have the 17q deletion syndrome, and some of them don't. So there are other sorts of deletions, but how many are we following altogether?
I think I'd have it better top of mind, but like
But maybe not
30s,
Really quick.
40s, maybe.
how
Yeah.
many?
I said maybe 30s or 40s. Ava's gonna look. I should have it more
Yeah,
top of
but
mind.
not a
But
hundred.
not a
So
hundred.
so I think every single case is important, and
Yeah.
to be able to capture these in some things. That's why, Michael is listening too. And we found this. We've Michael has helped start this thing called Predict, where we have a now up to 14 center consortium,
Mhm.
and we're trying to get a national coverage of essentially all the monogenic diabetes, but the more rare ones in particular. So
Mhm.
uh, to better understand things like hypomagnesemia and what the treatment. But so here we are. So um, where are we there? So there's one beta 42. So that's and we have this is out of like 5,000 people who've been reported to us, of which something like if you add up all those people, it's still not quite 1,000 maybe who
Of
have some.
HNF1 beta.
So
Or
Just of
42
of
have
the
one beta, but I mean of all the known monogenic causes, so GCK is far and away the most, and we're still learning about that.
yeah.
So I think the more cases we have, the better we understand. So this is a plea to try to think about
Yeah.
the registry and pool the cases when you can.
I think I suggested it to multiple of them. Probably for a variety of reasons, my HNF1 beta patients, this one's probably the most straightforward. Another one's like in DCFS custody. The other two have like very, very low medical literacy and are non-English speaking. Like they're difficult
Yeah,
cases.
for
So
sure, for sure, it's
I
hard.
get
But I'm intrigued that you you added an SGLT2. I mean, has it helped? So one of the things we
Yeah,
did
I
early
would love
on,
to honestly, that's the DCFS patient. I really wanted to publish it as a case report because I couldn't really find any. But yeah, she came off the amiloride. It went down on her magnesium dose. It's totally normal. Her blood sugars are totally normal. I
well,
mean,
it is interesting, right, Ro? Wouldn't, isn't
Yeah,
it
and we've
such a
had we
variable
so
response?
yeah, I mean, so I know definitively of two people in our registry who had tried SGLT2 inhibitors and had a good response. There's probably more, but two where I remember more details. And I think of, certainly, particularly if there is a renal, excuse me, the magnesium wasting, like I think that it becomes a very, very
yeah,
rational look. I'm always reminded that we sometimes have to also remind ourselves to look in the renal literature because right now it just doesn't feel like the renal and endocrine literature on HNF1 beta tend to talk to each other very well. So, but I can think of, oh goodness, the author's first name is Ray, but I cannot think of the last in terms of like the HNF1 beta from the renal side of things. So, I also dropped in the chat. That is the article that was
yeah,
like recently came through my Undermine that I haven't looked at it yet, but it looks like they in addition to describing their patients added like a kind of systematic review. So that should be very, very useful for us all to,
yeah,
ingest and then hopefully recall a lot of. We will, when I get out of the way soon and not be publishing our own HNF1 beta cohort,
uh-huh.
and all things to get that over, but yes, like just as Lou said, there is not a lot of data. And I think particularly anything where we are suggesting therapies, or utilizing therapies outside of insulin, I think is very, very important because even again, the distinction between needing insulin and being treated with it is a really hard one to make because, of course, anybody will respond to insulin, including people without diabetes at all, right? So we get really fuzzy about who needs it. I will say, I don't I mostly agree with Lou's point about, or his perspective on metformin. I will say that, a little bit of the tacrolimus is resistance, mostly, or well, maybe in each person, it's like probably more secretion, but there is some component, and I think it becomes a little bit of the side effect profile while they're still normal, and so I think that um for the reason of the tacrolimus, which adds a sort of another layer to it, it would, makes me a little more like, a little bit more like maybe do something. But in this case, because they are, not normally A1C, but still like below the diagnosis, and because there is a little bit of rationale in that
Yeah,
perspective, it could be thought of. Um,
yeah. To be honest, I just remembered that I just started metformin in another one of my HNF1 beta patients, and I working closely. It was actually very interesting because she recently went on an antipsychotic and gained like 30 pounds. So that's mostly why I started it, because she's already on insulin. But then kidney, I talked to kidney about it because she actually has a harder time controlling her magnesium. And I was like, how do you feel? Mom, she's on many, many, many medications. And I when we were talking, she was like, okay, is it going to affect her magnesium? I like really want to make sure. So I had a conversation with renal about it, and they were like, oh, actually, maybe it will. And I'm like nervous. So we've been like trying to go up on the metformin mostly for like appetite control, with like her rapid weight gain. And we're like closely watching her magnesium as we like titrate up. So
for
yeah,
for that patient,
technically, I actually do have her on metformin.
yeah, for that patient, is there a reason to not do a GLP-1?
The reason that we're not doing a GLP-1, there is a reason, and I can't remember.
Yeah, no, that
I
no,
think
yeah,
I think there was some reason that we didn't do a GLP-1 as opposed to metformin.
yeah,
I think because mom, yeah, she has so much polypharmacy,
yeah,
that there was some type of reason. But yes, I could probably do a GLP-1 too.
yeah.
Maybe. I'd have to like review.
Yeah, I think if the reason in that other case, if the reason wasn't like a hard fast one,
Mhm.
that in that one, I would say, be given the weight
Mhm.
gain, like
Mhm.
be like I would probably say like, okay, I'll trade daily metformin for once a week GLP-1, and I think that would be
Yeah.
a good trade there if there's not some
Yeah.
significant indication.
Yeah.
Super interesting. Yeah, no, definitely.
Yeah. Sorry that I have all the interesting
I was
HNF1 beta patients
well,
here.
hey,
And I don't know how they keep coming to me, to be honest. I am not recruiting them. Uh,
The point that I make over and over again is that
yeah.
they're coming to everybody,
Yeah.
yeah,
but you found them. And
Yeah.
that's the difference. They are out
Yeah.
there and we don't know how many there are because we don't know what the denominator is.
yeah.
Yeah.
So
To be
that's
honest, actually, multiple of them were misdiagnosed. Like
always.
that patient that initially came to me, the one that is now on an SGLT2, she had actually also had antipsychotic rapid induced weight gain. And so was severely obese. And she actually came to me as like a pre-diabetes patient because she was like 6.3. And I was like, wait, you have 17q12 deletion. You have this. And then another one, they only found it, he had the renal transplant and they thought that he had medication induced diabetes. And that's what they said he had for actually all three of them. They thought he had medication induced diabetes. And it wasn't until he had liver enzyme elevation that somebody did genetic testing on him. And then I inherited him after that. And I was like, I had to tell the mom, I was like, actually, you don't have just medication induced diabetes. It's because of this. And the third one had a zinc transporter that was like slightly positive, and they had told her she had type 1 diabetes until I got her and I was like, no, you don't. You have this.
Well,
um
I think that their child with autism
mhm,
has non-antibody positive diabetes, so antibody negative diabetes.
mhm.
And now I'm not sure what that is yet, but what's the percentage of kids with autism who get chromosome analysis?
A
I don't
lot
know.
actually at
So
this
this
point.
is
I
so
mean,
I'm
well,
not,
I
you can
should
tell I'm
say
not a pediatrician. So,
well, what I really should say is, a lot of the ones who have access to, you know, good, who have appropriate access to healthcare and intervention. So it's actually probably not actually a lot, but it is more.
Mhm.
It's done more and more.
because I
It
just
is.
in order, so with this, we went through this whole thing with this guy. First, said, well, your kid probably has type 1, and he goes, no, he doesn't. And then there's a whole family history, and it gets more interesting, but it relates exactly to what you said. But then I did a review, just again, my own.
Mhm.
I didn't use undermine this time, but I just looked for autism and diabetes, and that, so there's some papers say that there's a 2 to 3 fold increase of non-type 1 diabetes in kids with autism in general. But those
Mhm.
papers don't say anything about ruling out, for example, a 17q as one possible contribution. So
Mhm.
I think that the fact that you looked and it's a credit to you that you picked these up, and they might otherwise go unrecognized. I think that's the message we're trying to get out there more and more. I think generally speaking, the pediatricians and the pediatric endocrinologists tend to be way more thoughtful about this than the adult endocrinologists. So I think that's one of the things we're trying to
And
battle against.
just one quick comment about the
Mhm.
autism part, because of like when you first mentioned it, and Lou was mentioning, the underlying cause, that it's a little bit like diabetes in the sense that there are many paths that can lead towards autism, which is
Mhm.
really more of a clinical kind of symptomatic diagnosis, and there's certainly more awareness of all the possible underlying genetic causes. So I think more and more people are getting different kinds of genetic testing where it's not just cytogenetics that should be done, but point there are mutations and genes that need sequencing, and so there's more of that happening with autism too.
Mhm.
But it's really cool that you have these cases, and I was thinking, in order to facilitate joining the registry, there are different things that can be done because
Mhm.
ultimately it really just requires them kind of signing up on the website, and then we can
Mhm.
reach out to them and do most of the work. And
Okay.
so, like when they're in your office, kind of
Mhm.
helping them sign up,
Sure.
or in certain cases, we can even, depending on when you're seeing them, we could maybe even set up a call with Ava or one of our team to
Okay.
do the consent process, like while they're
Okay.
there. Because you have all those cases and,
Yeah.
maybe, when we have uh, like a small targeted number of cases in the registry that are of interest, we're always very willing and love to have the providers like you, join in publications and things like that.
Mhm.
We love that. So if there's a way to kind of finesse and make that happen, that would be great.
Yeah, like I said, one of them I know I can't make it happen, but the other three I think I could. It'll just be tough language
Well, it's
wise,
great. I
but
mean, for sometimes there's a fellow who can help
Mhm.
write it up. Sometimes we have
Yeah,
people with extra bandwidth, and so you
Mhm.
provide the background, and someone can put it together. And
Yeah,
uh, and I think it's a huge contribution in several different fields to put all this together. I
yeah.
mean, as you say, the notion that SGLT2s can help the hypomagnesemia, Ro mentioned two where it worked, but we have some where it didn't. It may depend on how old you are when you started,
Hmm.
and how much of the kidney, is still functional. So
Hmm.
there's a lot to learn about why that should be, and it may be there are point mutations or deletions that work better than others. So there
Hmm.
could be structure function relationships in terms of the genetics versus whether that's going to work.
Hmm.
We did put it in some of our papers. I think we've mentioned it before, and Ro is
Yeah.
right.
Well, and I was going to say, I mean, for reasons we don't understand theoretically with the, deletions or not, actually, I think, no, we do understand them. I forget it now, or at least we have some hypotheses, the royal we, not me, in terms of the renal feature, sometimes being, like where the renal function is sometimes being a little bit better in the deletions actually than the point mutations. And then, all I was going to add is, as we're talking about like the different genes with, autism and everything else, it is the LHX1 gene as the part of the deletion that, right now is, I think people hypothesize, or is the one that would sort of is the responsible, or at least one of the genes that may be responsible for the autism that we see in the 17q
Hmm.
1-2 deletion syndrome. But no, it's very interesting and a lot to learn. There are some genotype phenotype relationships, but a ton to unravel. I will say, with in our co with within our registry, one of the people who did respond nicely to an SGLT2 inhibitor had been diagnosed for quite some time, and so it's not going to
Mm.
be age alone. I don't know what the deciding factors are going to be between who does well and who doesn't, but it's certainly every every person being treated, like being in the literature is going to be helpful. So definitely,
Yeah.
if we can help in any way to have you share that information with
Yes.
the community, that'd be great.
Um,
Yes.
Another quick comment about treatment
Mhm.
of this individual is that with the kidney transplant and all that, if in the future there's medical complications or need for, increased steroids for acute
Hmm.
rejection or anything like that, they could obviously get hyperglycemia at that time.
Hmm.
And that doesn't necessarily mean they would have to remain on treatment. But also the consideration that you're saying about the discussion about shared decision making and whatnot is to really think about the renal implications and treating sooner rather than later, possibly with the SGLT. With the other one on metformin, they're already on an SGLT, did you say, or they
She's not, she has like, there's been some concern on my part. Part of why I haven't started it is because she came to me on like an insulin therapy and has always been very well controlled on like insulin therapy. She has like really severe behavioral issues, and like some incontinence issues, some
Yeah,
like hygiene issues. She has had she presented in DKA. I've been nervous
yeah,
about the SGLT2 in her.
understandably, yeah.
So I have not used it in her yet. Because she's been kind of like riding around, 6.9 for her A1C. So
Yeah,
I
no,
haven't
it sounds
rocked the
like
boat.
I
this
share,
for
yeah, I
both
share your nervousness with when you're saying
yeah,
kind of particularly with any sort of yeah, the height, just like
the
just because of the adverse
infection risk
effects. Yeah,
and
like
the
I
DKA risk, yeah.
yeah.
Yeah. So that's why I haven't used it in her. I felt so much better when it was like early on and they weren't insulin dependent and but Yeah, that's why I actually share both of them with the same nephrologist, and we've talked about it quite a bit, um, about whether or not we should start it and stuff like that. But that's why we haven't. I guess one question I had just as I think about it, because my other one, not this one, but the other one is in rejection for his previous transplant. And as I'm thinking about it, and this is just probably a dumb question, but if he required a retransplant, um, I guess with this mutation, if he got a pancreas transplant, would it recur? It shouldn't, right?
No,
I
no,
don't think so. I think
Yeah.
it is interesting, because the kidneys are dead, probably because they weren't removed, right? They're still there.
So I'm talking about a different patient. Yeah. So I think I'm talking about another one who's like 18 or 19 now, who had a transplant a long time ago, and he's in kind of chronic rejection, and they're about to relist him. And he is insulin dependent. And I just am considering whether I think he's 19, 18, 19, and whether or not he would be a candidate for a pancreatic transplant um, with his renal transplant, and whether that would be.
I think we have some cases
Do
like
you?
that in the
Okay.
registry, even like with
Hmm.
like 1 alpha and that kind of thing, weirdly.
Okay.
And yeah, it's more of a developmental problem with the beta cells in the pancreas, and so
Okay.
there wouldn't be
A
any
reason.
reason to think it would recur. And if they
Okay.
are already insulin dependent, especially, there's a good argument for considering that together. Yeah.
Okay. I just
And,
I thought so, but I just
and
wanted
Well,
to
plus
like
with
yeah, and
check myself.
especially, in the absence of autoimmunity. So,
right.
Right.
I think that could,
And they
I mean,
do
it's obviously a
also
big deal.
they also have the
Right.
risk of exocrine pancreatic insufficiency, so it's one of the rare cases where there's at least a little more rationale for the whole pancreas as opposed to like islets maybe. But
Mm-hmm.
Well, but
Okay.
the acinar part of the pancreas isn't hooked up usually. It depends on how they replace the pancreas. I mean,
Yeah.
well, I think the enzymes have to go somewhere. Don't they usually do like a
bladder, they hook
why?
some in some, yeah, it depends on the
Well,
surgery. In adults, they hook them up to the bladder and you pee it out.
well, I think that was in the old days, wasn't it? Then they
Well, I'm an old
realized
guy.
it causes, I think it causes a lot of problems that in
Yeah,
the
it
bladder.
did.
And so I think they now they do like a Roux-en-Y in the small intestine or something like that, I think. But I could be wrong.
Okay. Mm.
Also,
Okay.
the only downside is, or at least in my N of one of my own patient, not with one beta, with one of the other transcription factor modis, was just the waiting. Like he just was listed for so long, and sort of kind of finally decided to
Oh, as
just go
opposed
back
to a
in.
renal.
Yeah, so that he
Yeah.
went back in as just the renal, and I'll be
I
seeing him
see.
pretty soon after his transplant. But yeah, it was that was, at least in this instance, the downside, because it was like, well, he's gonna, yeah, he was, I had to have the kidney for a different reason, just a lightning striking twice genetically,
Uh-huh.
and then, but yeah, he just couldn't come off the list.
Couldn't
So
wait. I see.
yeah,
Got it.
yeah,
Okay. Well,
yeah,
I'm just going to mention it to my renal colleagues to like consider as part of their thing, because I doubt they're
yeah,
considering it because they
yeah,
still write in their notes that he has medication-induced diabetes.
yeah. Yeah. So yeah,
So,
definitely. It's like, yeah, if he could come off and do both, like I think that's very, very reasonable. That was the plan for this
that guy.
patient. But it just,
Okay.
yeah, just like a couple of like um thoughts that the transplant, a couple of the transplant falling through. And so
Mhm.
just kind of realized it would be easier.
Okay. Okay. Sorry that we ended up talking about all four of them, but
No, this is
No, I think
I
awesome. I
that's the
think
appreciate
beauty of
it.
it. There was no way. We would rather spend the
Yeah,
whole time on one patient than
yeah,
give short shrift to two. So we can
yeah,
save the second one for another time.
yeah,
yeah.
And appreciate your being here for this length of time. I wasn't
yeah,
sure you
Yeah,
could, but
I thought my 2:30 meeting got canceled. So,
lucky us.
yes.
yeah,
Yeah,
But
thank
I
you.
do think it just I can't emphasize enough the importance of basically they always say chance favors the prepared mind, and actually
Hmm.
somebody said that. So uh if you keep your eyes open and you look for unusual things, you find them. That's really the difference. And so I think the more you do that, you have enough for a series here, let alone a single case report. So I think it's very important. So we appreciate your time and your
Yeah.
sharing this with us. And if we can, as we said multiple times, if there's anything we can do to facilitate, either the care or the writing up or additional investigation, we'd be happy to do that.
Okay. Thank you so much, guys.
All right. Take
I'll be
care.
in touch. Thanks. Bye.
Okay, and that brings us all to a close. So we'll stop here, Ava, right? And